In this video, we shall be discussing a few inflammatory and infections of your skin that we generally come across in our surgical practice. So let's begin our discussion with your inflammatory condition. So first we have your hidradenitis suppurativa. So these are characterized by your follicular occlusion, folliculitis and a secondary infection. So you can see the image given over here of hidradenitis suppurativa. Now this is usually with your Staphylococcus aureus and your Propionibacterium acnes. Now hidradenitis suppurativa culminates in your chronic suppurative painful skin abscess, sinus tracts and can result in scarring. It affects your apocrine gland bearing skin in the axilla, groin and less often your scalp, breast, chest and your perineum. It is much more common in women compared to men. Now, it has a genetic predisposition but a variable penetrance and is strongly associated with your obesity, smoking, sex hormone. It starts at the puberty and often resolves at the menopause. So, the management would include your stopping of smoking, lose excess weight, antibiotics, anti-androgen drug and the selected patients would require your radical excision. Then we have your pyoderma gangrenosum. So this is the image showing your pyoderma gangrenosum affecting the legs and the breast. So this are again characterized by your rapid onset. Then they are painful cutaneous ulceration with your undermined edges. Now, they are secondary to your heightened immunological reactivity, usually from another disease process such as your inflammatory bowel disease, rheumatoid arthritis, non-Hodgkin lymphoma or your granulomatosis with your polyangiitis. Now, this usually respond well to steroids. So, your treatment would be your steroids and surgery is rarely indicated, rather it can exacerbate the conditions. So this were your two inflammatory conditions. Now coming down to few important infection. So first we have your impetigo. So what is your impetigo? So you can see over here it is a superficial infection of the skin which is usually caused by your staphylococci, streptococci or both, and it is highly infectious. So there are characteristics blisters that coalesce to form your honey colored crust. So you can see over here your honey colored crust formation. Now it usually affects children and treatment is directed at washing the affected areas and applying topical anti-staphylococcal treatments. Your broad spectrum oral antibiotics are required if streptococcal infection is also implicated. So please remember the causative agents which are your staphylococci, streptococci, highly infectious, usually in children. Then your next infection is your erysipelas. So if you look over here, this is your image showing your erysipelas. So this is a sharply demarcated streptococcal infection. So the most common confusion in this question arises in the causative organism. So please maintain a chart that which skin disease is caused by which organism, which is going to help you. So over here you have your erysipelas which is caused by a streptococcal infection of your superficial lymphatics, which is usually associated with your broken skin on the face. So the area affected is your erythematous and edematous. Now patients will be febrile and may have a leukocytosis, and the prompt administration of your broad spectrum antibiotics after swabbing the area for culture and sensitivity should be your treatment of choice in these patients. Now next we have your cellulitis. So you can see over here cellulitis affecting the left leg. So what is cellulitis? It is your bacterial infection of the skin and the subcutaneous tissue that is much more generalized than your erysipelas. It is usually again associated with your broken skin or a pre-existing ulceration. Now, it is characterized by your expanding area of erythematous edematous tissue which is painful, and you have association of fever, malaise and leukocytosis. Erythema tracking along the lymphatics may be visible, and that is known as your lymphangitis. So what are your commonest organisms involved? They include your Streptococcus pyogenes and Staphylococcus aureus. So what you need to do, blood and skin cultures for sensitivity should be taken before your prompt administration of broad spectrum IV antibiotics, and you need to keep the elevation of your affected limb. So generally this resolves with the use of your antibiotics. Now next important condition is your necrotizing fasciitis. So please remember that Milanese synergistic gangrene and the Fournier's gangrene are your variants of your similar disease process. So they result from your polymicrobial infection. So your first important point that you need to remember regarding your necrotizing fasciitis is that it is a polymicrobial infection. So the most commonly group involved are group A, beta hemolytic streptococcus in combination with your staphylococcus, E. coli, Pseudomonas, Proteus, Bacteria and Clostridium. So you have your 80% of patients with your history of previous trauma infection, and over 60% of cases occur in your lower extremities. So what are your predisposing conditions? So predisposing conditions include your diabetes mellitus, smoking, your penetrating trauma, then you have your pressure sores, immunosuppression, intravenous drug abuse, perineal infection in form of your perineal abscess and your Bartholin cyst, and would also include your skin damage or infection. Now, the various classical signs include your edema, which is stretching beyond the visible scaled erythema. Then you have a wood-hardy texture to the subcutaneous tissue, inability to distinguish your facial planes and muscle groups on palpation. Now, disproportionate pain in relation to the affected area and associated skin vesicles and your soft tissue crepitus. So, these are some of your classical features that will help you to recognize the clinical entity of your necrotizing fasciitis. Now, lymphangitis is usually absent, and early the patients may be febrile and tachycardic with a rapid progression to your septic shock. Now, which makes it very important that you treat your necrotizing fasciitis patients early. Then you have radiographs, which should not be delayed for your urgent treatment, and what it does is that it would help you to demonstrate air in the tissues, but then it is a surgical emergency and you need not wait for your radiographs to be done in order to start the treatment. And the management, as I said, is a surgical emergency, would require your urgent fluid resuscitation, monitoring of the hemodynamic status, and administration of your high dose intravenous broad spectrum antibiotic. So the surgical emergency and the diseased area should be debrided as soon as until viable healthy bleeding tissue is reached. So we need to go for an extensive debridement in such cases until we find a healthy tissue. Early skin grafting may be used in selected cases that may minimize the protein and tissue loss wherever available. Now this is a new entity which has come up, that is a hyperbaric oxygen therapy after debridement is helpful, and they have your high mortality rate, that is 30 to 50% even in spite of giving your prompt treatment. So please do remember this your necrotizing fasciitis. I have taken this image where they have shown your affecting your left orbit. So, but as we had discussed, it is much more common in your lower extremities. So you might get a situation where they have given you an image of your left lower limb, or they can use this image which is used in your Bailey and Love. Now next we have your purpura fulminans. So this is again a very important entity. So this is a rare condition which is characterized by your intravascular thrombosis causing your skin necrosis and your hemorrhagic infarction, which eventually leads to your septic shock and your DIC. Now the age group that is commonly affected is your children, and it occurs in your three forms: acute infectious, neonatal and idiopathic purpura fulminans. The most common is your acute infectious form, right? Yes, so the most common form is your acute infectious form, and the responsible toxin is said to be your endotoxin, which causes an imbalance in the procoagulant and the anticoagulant activity, causing a deficiency of protein C, which is responsible for your clinical picture that is characterized by your skin necrosis, hemorrhagic infarction, and eventually leading to a septic shock and your disseminated intravascular coagulation, right? So the extensive tissue loss is common and it eventually culminates in your limb amputation. So this were your few important points regarding your infective and your inflammatory conditions from your skin.